topics and opinions expressed in the following show are solely those of the hosts and their guests and not those of W4CY Radio, its employees, or affiliates. We make no recommendations or endorsements for radio show programs, services, or products mentioned on air or on our web. No liability, explicit or implied, shall be extended to W4CY Radio or its employees or affiliates. Any questions or comments should be directed to those show hosts. Thank you for choosing W4CY Radio.
Welcome to the Ask the Expert show on W4CY Radio and Talk4 TV, where we bring you educational information from top local experts in the fields of legal, health, financial, and home improvement. Now sit back and listen to experts in family law, association law, hearing loss, business brokers, home care, along with many other topics. Now here are your hosts, Steve-O and Sophia.
Hey, good afternoon, Houston. Welcome to another Ask the Expert show where we bring you the top experts in the field of legal, health, financial, and home improvement. This show today, first of all, I'm so glad it's 50 minutes long. It is so near to my heart because, well, I don't know if I can say I suffer with sleep apnea because I am on a CPAP machine, but I know what people go through who have sleep apnea. And, there's a lot of different clinics that we could have gotten to do this show. What's so great about the Sugarland ENT and Sleep Center is Dr. James Ludwig. He is an ear, nose, and throat doctor. It's sometimes we get in some of our other markets, a dentist who does appliances. But with Dr. Ludwig, there's so many ways that he can treat you for sleep apnea. So let's welcome. I am so glad we have Dr. James Ludwig. Hi, James.
Hey, good afternoon. How are you?
Okay. Hey, we're going to have to give you some sugar or something. This is your show, bro.
That's right.
Tell people, first of all, about your practice.
We're located in Sugarland, Texas, right near University in 59. And for just about 20 years, I've treated sleep apnea, sinus allergy, general ENT. I had my own sleep lab for about a decade, so I did a lot of real in-lab testing. That you have all the wires. I'm sure you went through that back in the day. Now we do home testing.
Yes.
I'm fellowship trained in sleep medicine. I did my fellowship at Baylor with Max Hershowitz, who's a pretty well-known. He's a PhD and an MD, but he's very well known in the sleep community, and alongside the pulmonologist. So as far as to my knowledge, the only fellowship trained sleep medicine ENT physician in probably the southern United States. There's very maybe 2 or 3 of us in the whole country. So I have a lot of experience treating sleep apnea with air pressure, of course, and then helping people find other solutions or helping them be successful with air pressure if they weren't before. So we do sleep surgeries, nasal surgeries, sinus surgeries, oral appliance therapy, CPAP fitting, dispensing, troubleshooting, pretty much anything related to and all the above for sleep apnea and sinus and allergy problems.
Well, I know this is a sleep apnea show, but you're an ear, nose, and throat doctor. So tell other areas that you treat besides sleep apnea.
I do. Today was like an ear day. I had a bunch of people come in. Someone had perichondritis, which is an infection of the pinna, holes in the eardrum, outer ear infections. I had a lady I saw that had vocal cord paralysis after a thyroidectomy done by another surgeon. So swallowing problems. I saw a kid today who had prior tonsillectomy, and he had sore throat and a big swollen neck mass. It was a lymph node. He actually had adenitis, it's like tonsil tissue, but in the back of your nose. It's exact same tissue. And so he had a severe case of adenitis, and which is treated like tonsillitis. So it's amazing. Yeah, ENT is a pretty cool field because there's a lot of things that we treat that are, hearing, a lot of your senses, smell, swallowing, speech, nose, voice box, throat, head and neck cancer. I diagnosed, unfortunately, I saw one of my patients who's been on CPAP for years. And kind of the reason I make people come in once a year, I don't make them, but I request they come in once a year is he came in for a CPAP visit and actually had a big neck mass, and turns out he's got base of tongue cancer, most
Oh,
likely. So that was not pleasant. But I mean, I'm trained in all those things. I was fortunate enough to train Baylor, and Baylor's top 1 or 2 programs in the country. We get to work at the VA, Ben Taub, Children's, Texas Children's, Methodist, St. Luke's, MD Anderson. I mean, just the amount of patient diversity that we get there is just phenomenal. So, yeah, I do treat a lot of things. I just have a real special interest in just a ton of experience in sleep and sinus.
somebody, a listener, asked me if you do rhinoplasty.
No, no, I don't do cosmetic surgery. I wish I did. I'd probably have a bigger bank account, but I I do open noses to fix nasal septal deformities, but I don't do cosmetic rhinoplasty procedures.
Okay. Well, I was telling you right before the show because we started promoting it on iHeart and Facebook and Spotify, your show, and we got so many questions from listeners. So um,
Favorite?
I'm just going to jump right in.
Sure.
Uh, Here's Greg. And now this is amazing because we really target the Houston area, but this is from Greg in Austin. He said, I really enjoyed Dr. Ludwig last month as I have a snoring problem. He said, I live in Austin. Does he do telemedicine?
Sure. Yeah, I mean, I can't scope you over the video,
Yeah.
but I can certainly educate. And I mean, a lot of what patients are missing is education. I think that's a big void in a lot of physician-patient encounters, unfortunately. So I think education is one of the most important things that we do to help people make decisions and choices. And so I think just getting good information can be very valuable. I always tell people my staff or my son or anyone I'm trying to teach that the only thing worse than no information is misinformation. So
Yes.
I try to give good information. At least if I don't know, I'll tell you. But uh, we find a lot of misinformation in my office. Patients that come in, a lot of misinformation or no information. So certainly good.
James, you do sleep tests. People do them at home now. And like I said, when I did it, you had to go to a sleep center and spend the night there. With can you do a sleep study from anywhere, or do they have to be in the Houston area?
No, because you could order one and have a local. I mean, some companies mail them to you. They'll mail you the kit and then you do it and you mail it back. In my office, we have them. We have several of them. We hand. I mean, I want to make convenience part of the experience. So when I see a new patient or an undiagnosed patient or a patient that we need repeat information on, I just give it to them right there and then they bring it back and then we review it the very next day, which is really convenient. But you could, pardon me, you could get a test done anywhere from and then review the results. You don't have to, come to my office to get a test.
Okay. Ricky and Friendswood, do you actually stop breathing if you have sleep apnea?
So there's two. Well, when I teach patients about sleep apnea, I mean, one of the points I make to patients is not enough air is not enough air. It doesn't matter if it's not enough or none, because like a car engine, either it runs or it don't run. It's, not some gas isn't enough gas. So when you are sleeping, you need a certain minimum amount of air to meet the oxygen demands of your body while you're asleep. So anything less than that minimum is a problem. And sleep apnea has three. When you do a sleep study, like especially the one that you did, Steve, the in lab, there's basically three things they count as far as breathing, as far as the umbrella of sleep disorder breathing. So one is apnea, and apnea is when you have less than 10% of the normal flow for at least 10 seconds. So these events, first of all, have to last 10 seconds. If they last 5 seconds or 6 seconds or 7 seconds, they're not counted, even if they're occurring. So you have to have and then for apnea, you don't have to have any oxygen desaturation. Your oxygen dropping is not a criteria. So if you just have a 90% or more cessation of airflow for 10 seconds, that's counted as a problem. And then the second type of airflow issue is called, I'm talking about obstructive sleep apnea only, is called a hypopnea, which comes from the word hypoventilation, which means not enough. So hypopnea is a 50% reduction for 10 seconds with a desaturation. So that's why we measure your oxygen while you're doing a sleep study. Whatever test you do, a watch pad or the home test kit or in-lab oxygen sensing is one of the things you're measuring. So if you have a 50% reduction of flow and a desaturation, then that's called hypopnea, and it's 3%. And then there's a third number called a RERA is the acronym, and RERA stands for respiratory effort related arousal, or backwards, it's an arousal from sleep caused by a increase in effort of respiration. So your brain's coming out of sleep or it's being interrupted because of the effort required to get the air you need. And then a RERA is when your oxygen isn't dropping 3%, maybe it drops 2% points or 1 percentage point, but you're having a reduction of flow, and that reduction of flow and the increase in effort is causing you to have to come out of sleep. So then that arouses your sleep. So basically, a RERA, a hypopnea, and an apnea, you would add up all those events, and then you would divide by the amount of time that you were observed while you're asleep. And then that would give you a mathematical simple average. So let's just say you were in the bed, you were asleep for 8 hours, and they counted 80 of those things, add them all up, 80 times that you had those events over the 8 hours, then your average would be 10 per hour. And that's how that number 10 is how we communicate from one person to another. It's kind of, just a way to try to communicate to another individual how quote unquote bad or not bad you are. But like anything, when you have a lot of analog information and you try to boil it down into a single number, you lose a lot of resolution, right? It's like having 1 pixel for a photo instead of having a million pixels for a photo. So, and the reason I bring that up is that when people obstruct, there can be extrinsic and intrinsic factors that can either make it worse or better. And for simplicity, let's just say, like, for example, some people, when they're not on their back, they breathe a lot better than when they're on their back. And a lot of people will say, oh, I never sleep on my back. I don't like sleep on my back. And they think, it's a chicken and the egg phenomenon. Do you not sleep on your back because you can't breathe on your back? And so even though you're unconscious, you unconsciously kick yourself over? Or do you not sleep on your back because it hurts because you have back problems or whatever? So you can have what's called positional sleep apnea. So imagine you do a sleep study and you spend 90% of the time on your side, and then you spend just 10% on your back, and then, oh, you don't have sleep apnea, even though you feel bad. Your doctor's like, oh, you don't have sleep apnea, or at least clinically significant, because they diluted down the whole time on your back with 90% of the time on your side. So I make sure that patients always get a significant amount of observational time. I want them to sleep on their back and on their side when they're being tested, so that we can figure out if there is a difference.
Yes.
Yeah, because what if you slept on your side all night and then now you're quote unquote negative, but really you have it, but you miss it. So, and then some people, I talked about intrinsic factors. So intrinsic factors is like, are you a drinker? Do you drink at night, or do you do sedatives at night? Sedatives are going to make your sleep deeper, which makes you more relaxed, which makes the ability to have obstructions easier. And then it'll make those obstructions longer, because the way that you fix an obstruction is you come out of sleep. So if you're had 2 or 3 drinks before you went to bed, then it's going to be harder for you to have an arousal to fix that obstruction. So it's going to exacerbate sleep apnea, and then there are patients who have what's called REM-related sleep apnea, which is where sleep is divided into 2 main stages: dream and non-dream sleep. People often confuse dream sleep with deep sleep. Deep sleep is not dream sleep. People think you don't get dream sleep when you have sleep apnea. People think you don't get REM sleep or dream sleep or deep sleep when you don't have sleep apnea, but you get both of those. And so some people, it's kind of cool, actually. It's kind of amazing. Only obstruct their airway when they're dreaming. And the reason that would happen is because when we dream, our muscles are completely paralyzed. The only muscles that have any tone in your body when you're in dream, there's three muscles. It's a middle ear muscle, it's your ocular muscle, so you can move your eyeballs, and it's your diaphragm. Outside of those three muscle groups, your leg, your abdominal muscles, your biceps, everything else is zero muscle tone. If you put an EMG electrode in those muscles, there'll be no electrical activity whatsoever. So
Wow.
they-
Never knew that.
yeah, only the human body, right? Only nature can paralyze your whole body, but not your diaphragm. So, and your eyeballs. So when you dream, they call it rapid eye movement sleep because your eyes are moving back and forth intermittently, rapidly. That's why it's called REM sleep. And REM sleep, if you guys, just look it up. It's pretty interesting. There's a lot of physiologic things that go on during REM that don't occur during non-REM. And when we cycle through our stages, we cycle through stages about every 90 minutes. It's different for different people, but on average, every 90 minutes, whether you know it or not, you're having a dream period. And
Did
the way
not
that
know that.
the way that they know
And we
that
get a lot of people who ask, what is REM sleep?
yeah,
A lot.
the way that we know dream sleep is through empiric observation. So basically in the 50s, before the field of sleep kind of blew up with people that became interested in studying it, sleep was called non-wake. It wasn't called sleep. It was wake and non-wake. And so either we're awake or you weren't awake. Okay. And then they figured out over time by doing lots of EEG tracings while people slept is that you could categorize sleep into like four, like if you were to do 30-second views of sleep, electrical activity, and you were to just have a random observer get these sheets of paper that represent 30 seconds of real time and look at your EEG, people would put them in like four piles, four piles. And one pile was light sleep, and one pile was stage 2, and one pile was deep sleep, and then one pile was REM sleep. And that's how they figured out that there were these different stages. And the way they figured out that rapid eye movement sleep is dream sleep is that they watch babies, infants, sleep in the nursery because their eyelids are very thin, and babies spend half of their sleep time dreaming. Adults only spend 20% of their night dreaming. So, and because their eyelids are thin, they could just look at the babies and see their eyeballs moving rapidly under the eyelids.
Wow.
So then what they did is they brought adults into the laboratory and they had the adults sleep. And then when they saw the eyes moving, they woke them up. And then they would ask them, what are you doing? And the patients would say they're dreaming. And that's how they figured out that rapid eye movement sleep was dream sleep. Because how else would you know? There isn't like you can just see it. You can't see a dream, right? And then so there are a lot of other things like you lose thermal regulation in dream sleep. That's why you can wake up freezing because you don't have any thermal regulation when you're dreaming. And there's a bunch of other, in fact, your brainwave activity when you're dreaming is just as active as when you're awake. If you put the EEG of a patient dreaming, and that's the only thing you can see is the EEG, and you put an EEG of an awake person, they look the same. You can't tell by the EEG they're asleep. The only way you know they're asleep is you need the eye movement channel to see their eyeballs moving back and forth rapidly, and you need the muscle tone channel to see that they have no muscle tone, because if you're awake, you would have muscle tone.
Right.
So yeah, dream sleep's a whole other animal. And some people, when they're dreaming, they lose this muscle tone, and breathing is more regular in dream. There's a lot of things that make dream special, but they lose their airway when they're dreaming, and so they'll only have sleep apnea events when they're dreaming. And the reason I'm spending time explaining this to you is because I just told you that dream sleep only makes up about 1/5 of your night. Okay. So let's pretend you're one of those patients who only has sleep apnea events when you're dreaming. And the reason sleep apnea events make you feel bad is because you have to interrupt your sleep to restore your airway patency. Then if you do like a home test, which can't tell which stage of sleep you're in, it just knows if you're breathing or not breathing. Okay. And then it comes back with some low number, like, 8 per hour or 10 per hour, which is still clinically significant. But, I have people have 80 per hour or 70 per hour or 60 per hour. What could be happening is that when you're dreaming, you could be having a ton of them per hour, like 50 an hour, or 40 an hour, or 30 per hour while you're dreaming. And then when you come out of dream, it's like a switch, and then you start breathing normally. So what happens is that fragmented sleep gets diluted. The severity is masked by the time you're not dreaming. And I can tell you from doing this for a long time, that people who suffer from dream-related sleep, once they get to about 15 to 20 obstructions per hour just during that period of dream, it will impact their quality of life. If you treat that patient effectively, they'll feel better, even though their overall average is low. And the other reason I bring it up is that dream sleep is probably the hardest sleep to clear. Sorry, docs.
It's okay.
Dream sleep is the hardest sleep to treat because you're paralyzed. So it's the hardest stage of sleep to maintain patency with, a surgery or any other treatment. So that's why air pressure, especially for dream-related patients, oftentimes is, it's better because the air can actually dilate the paralyzed, collapsing airway. Does that make sense?
Oh, absolutely. I've never heard that before.
So,
Um,
a lot of times you'll do a
go ahead.
surgery on somebody for sleep apnea, and they'll have like their first study, they'll have events all night long. You can't see the dream component. And then after their sleep surgery or whatever treatment, it even applies to air pressure. But the procedure will be effective at clearing the non-dream events, much more so than the dream-related events. And then when you retest them, their average goes down, but you'll see when they're dreaming, they have these residual, disease during dream sleep. So I don't, teach this to every patient that I see, but these are just the subtleties of sleep disorder breathing that get lost in the, big topic of sleep apnea.
James, you've been doing the show for about 5 months now, and I read every single letter. And I got to tell you, I was shocked. First of all, most of them are men. Does that surprise you?
What, that men have sleep apnea?
Yes.
More so. Yeah, more men do have sleep apnea, but a lot of women have it, but definitely more men have it than women.
Most of the letters are from men. And
Yeah,
you just explained the medical. I am your best salesperson
yeah,
because so many of these people said, it's not a big deal, especially like if you don't have, if you're not married, if you're single and you live alone, it's like it's really not that big a deal. And I have shared this with you so many times. First of all, I'm going to tell you one of the biggest reasons why it's a big deal because I would find myself falling asleep at the wheel.
yeah,
I don't ever have that problem now that I took care. But it was so dangerous that during the day, and it was embarrassing talking to somebody and all of a sudden falling asleep. And they're
yeah,
going, gosh, am I that boring? And then the third one was I was in a class and I fell asleep. And of course, I start snoring, and the teacher had to wake me up. The whole class heard it. It was so embarrassing.
yeah,
And I am telling people it is so important. You people in Houston have got one of the greatest ENT doctors and sleep centers in Houston with Dr. James Ludwig. Don't let this linger on. I am telling you, I did that, and I am so sorry that I didn't get it treated sooner.
yeah. Well, you're very severe for sure. But people ask me if snoring means you have sleep apnea, and it doesn't. But if you snore really loud, when you think about it, what makes the sound of snoring is, first of all, if you snore, it's because you're developing airway resistance. You don't snore when you're when you're awake. You're not snoring at work. You're not snoring, when you're laying down awake. You only snore when you're either basically drifting off to sleep or asleep, when you're very, very relaxed. And the sound of snoring comes from a relaxed, restrictive airway. And when you're awake, you hold your airway open. That's why you don't snore.
Mhm.
So if the tissue that's vibrating for the most part is your palate, and a palate is small. A soft palate is, I don't know if people can
You
see me, but
showed us pictures of that.
yeah, it's not they're not big. And imagine how hard you must be pulling to make that poor little thing vibrate so violently that people can, say you're like 10 out of 10 or, 8 out of 10 or whatever it is. So if you're snoring like that, yeah, you got sleep apnea. If you're a quiet snorer, it doesn't mean you don't have sleep apnea, but if you have very loud snoring, that's a big sign that there's a lot of airway resistance. And, what's also interesting, is I have a lot of patients that are skinny that have sleep apnea. A lot of people that have have small chins or retrognathic. A lot of guys that are like that grow goatees or facial hair to
Hmm.
kind of balance out their face. They may not even know they're doing that, but that's, common. I see it a lot that guys with facial hair, not always, of course, but tend to have, they're a little bit underdeveloped the lower third of their face. And so it's a way to, cosmetically balance themselves out. But what's great about those patients that have sleep apnea that have those anatomic features is they do really well with oral appliances. And because an oral appliance is addressing why it is that they're having sleep apnea. So you don't, I mean, some people have epiglottises that are posteriorly tilted. I mean, they can have big lymphoid tissue, a lot of tonsils or lingual tonsils. I'm sorry, pharyngeal tonsils or lingual tonsils or bad nasal problems. Not everyone needs a CPAP machine, I guess is my point. There are a lot of other things that we can identify um, that can, at the minimum, make you a lot better, if not quote unquote cure you. Um, but you don't know unless you look. You have to look to find. But it's not just being overweight that gives you sleep apnea, for sure.
Jason in Memorial said, I know you're talking about sleep apnea, but you're an ear, nose, and throat doctor. Uh, is it, are the commercials on TV about hearing aids, the cheap ones, are those any good at all?
Well, I'm not an audiologist, so and ENTs don't dispense hearing aids.
Okay.
If an ENT practice dispenses hearing aids, it's because they have an audiologist on staff
Ah,
or
okay.
contracted that's in the same building and this shares or takes a room up or something and maybe shares in the profits. But an ENT's job is not to fit hearing aids. An ENT's job is to make sure you don't have other pathology that would make it indicated to get a hearing aid or to make sure you're a candidate for a hearing aid. But knowing, is the Siemens hearing aid better than the Audion hearing aid better than, I don't know.
Okay.
I don't fit them, and no ENT does. We're not even trained during residency on. I mean, I think we get a lecture maybe about hearing aids, but like I said, our job is the fixed holes in eardrums and fluid in middle ears and cholesteatomas and canal stenosis and acoustic neuromas and Meniere's disease and anything else and everything else that might be giving you ear pathology. But if you have either nerve damage, hearing loss, or you have conductive hearing loss that you don't want to do the other, say, a surgical intervention that to address that loss, and you want a hearing aid, then honestly, the audiologist is the best. Now they want to protect their revenue, so they're going to tell you they're better. But
Right.
I think it's always cost benefit with anything. So I think if the cost for the trial is not that much, then I don't think you have much to lose to try. And if you're satisfied, you're satisfied. Because I will tell you for two things. The best hearing aid, because I do work with a lot of audiologists. Don't get me wrong. The best, and just from the patient side, this is not an audiologist teaching me this. This is not my teachers
Okay.
teaching me. This is my patients teaching me. But there's a hearing aid called a Lyric, Lyric, and I have no interest in Lyric or any financial interest in there. But I will tell you that I had this audiologist that dispensed this hearing aid, and what's cool about it is it's like a small piece of foam, and inside the foam is the hearing aid, and they slip it in your ear canal, so it's about 2 millimeters from your eardrum, so you can't even see it anywhere. And you leave it in; it's like a disposable contact. You leave it in for a month. You don't actually take them in and out, and you throw them away when you're done, and you put a new one in. Okay.
Wow.
Yeah, and you can't have like a huge amount of
So you
loss
can't
because
see it either.
they can't see it, you can't anything, and they sound apparently amazing. And but they're not very powerful. So if you have a lot of hearing loss, they're not strong enough, for everyone. But again, that's where an audiologist expertise would get you in the right direction. But what I will tell you is the patients, patients never love their hearing aids. Patients love these hearing aids, even though they're pretty expensive. And the reason I was seeing them is because it sat in the canal. Like anything that sits in there and isn't removed, it sometimes would create problems. It would cause erosion of the, it would cause the skin of the canal to die from pressure necrosis. They would get, problems, infection, whatever. And sometimes I have to tell them they can't wear them anymore. And they would be the most upset patients that they couldn't get a lyric again because of some unfortunate complication of their ear canal from the device. And even people who had complications still love the damn thing. So I have a good friend of mine who's about 15 years older than me he's a lawyer, and he's a very busy lawyer who wears hearing aids. And I can just tell you that hearing aids are right below CPAP machines as far as people don't want to deal with them. It's
I'm
like
surprised at that.
yeah, people will deal with glasses and contacts and stuff, but man, I tell you that again, it's just a lot of it is just the public perception, I guess, of hearing aids. But they are a lot more work. They're a lot more work. You have to change the batteries all the time, like every 2 or 3 days and whatnot. So getting a set of hearing aids is really, I think it's more of a investment and a thought process than a CPAP machine. Hearing aids can cost you $5,000 or $6,000 for a pair. A CPAP machine will cost you, even if you pay cash for it, $1,000 or $1,200. So, and a CPAP machine saves your life, and the hearing aid doesn't. So,
That's
I
true.
mean, yeah. So, yeah, it's a personal decision, but long answer to short question is no, I don't. Other than that, what I've told you, know too much more about hearing aids.
Here's a cool question, James. I saw where you're an ear, nose, and throat doctor. I'm so glad there's a show like this on. Have you seen any side effects from COVID in the throat area?
No, the only side effect that's related to my specialty that I've seen is anosmia, which is a loss of smell. I have seen patients who have a lot of other complaints purportedly from COVID, but I don't know of any throat
She said
pathology.
she developed a lump in her throat and she wanted to know if it could be from the injection.
Well, so I see a lot of that complaint. Well, we call it globus sensation, which is lump sensation, and it's usually something that's creating chronic irritation, like reflux that you may not know you have, or postnasal drip that you don't know you have. You'd be shocked how many people that come to my office, Steve, and tell me they have no nasal congestion. And then I look in their nose and it looks like a train wreck. I mean, you would
Oh
be
my
just
gosh.
shocked the number of people that don't know they have bad nasal pathology. And it's just like sleep apnea. It's honestly like any other chronic pathology where you have it so long, you don't even know you have it. It's pretty amazing.
Wow.
It really boggles my mind. And I have these big 50-inch, TVs, monitors. And when I do my exams, I take photos of everything that I'm seeing, and I show all my patients their photos. It's like it's like if I don't show them, they don't even believe me sometimes, because they literally believe they have no problem until I throw it up on the screen, this big in front of their face, and they're like, "Wow, I didn't even know I had that," And we have a CAT scanner in our office, and cone beam scanner, and we find so much sinus disease that people don't know they have, that they seem to have, I mean, there are always people who have symptoms, but there are just a lot of people who really blow off their symptoms, and they do the same thing with sleep apnea. They blow off or diminish the effects it has on them because they either attribute it to other reasons, or they're really honestly just not aware because they have it all the time.
Elizabeth in Northwest Houston. Oh, this is a good question. What are your feelings on surgery for stop snoring?
Well, for snoring, yeah, I mean, snoring is a very challenging problem because there's only two ways to stop snoring, right? It's to either resolve the airway resistance that you're developing that causes the snoring, And then the other strategy that we've used fairly unsuccessfully, honestly, is to try to keep the thing that's vibrating from not vibrating without actually correcting why it's vibrating. If that makes sense what I'm saying.
Yes.
So there are a lot. If you look at the history of palate procedures for snoring, I would tell you to stay away from those, because that's like burning the palate, injecting the palate with alcohol, like 95% ethanol, pillar implants, which, I'm sure someone made a lot of money on that, but they don't really work that great, because the problem with all these procedures is they're all based around scarring. They're going to damage the palate. Now, when I say palate, I mean soft palate. They're going to damage the palate to create scarring and fibrosis, which is scarring, to create rigidity, to help prevent flutter. And people get their uvulas amputated. That's like malpractice. That's totally retarded. To stop snoring. People that have big uvulas, it's again chicken and the egg. They have big uvulas probably because they snore, because snoring beats the crap out of your palate all night long. That's why you wake up with a swollen palate. When people come see me, I ask them if they snore after I examine them. I already know if they snore. They're not telling me something I don't already know.
Right.
I just want to know if they know, and if they appreciate how bad it is. And again, it's everything comes down to the pictures. You show them their throat, you show them their uvula. So the better way to treat snoring is to try to reduce the resistance. And oral appliances can be great for snoring, because they actually give you more airway space for most people. And then, it's kind of similar. The problem with snoring is that it's not considered a medical problem, so your insurance isn't going to cover, like, technically snoring procedures. If you snore because of nasal congestion, then they will cover nasal breathing problems. And if your side benefit is less snoring or no snoring, that's great for you, but that's not why we're doing it. We're doing it to improve nasal breathing, which decreases upper airway resistance, which can improve snoring. But I don't necessarily do nasal surgery for the prime purpose of snoring, because it's hard to predict, but I do nasal surgery to improve nasal breathing, and that I do guarantee that it works every time. So, and the problem with snoring, it's the same thing. Guy comes in and says, my wife says I snore, and she's complaining, and then they don't want to spend the money to not snore. So when they find out it requires some kind of work on their part, they thought it was going to be like a pill or something, then they're a lot of times they're not interested in doing anything. Well, I'll tell you, women are usually much more faithful than men when it comes to trying to make their partner happy. By faithful, I mean, if a woman's the one who's snoring and their husband's complaining, they genuinely usually want to do whatever they can do to make it go away. But I would say that guys are not as genuine. I won't say all guys aren't as genuine, but I will say it's not uncommon for someone to find out what they need to do to stop snoring, and then you never hear from them again. So if they're a guy, so guys tend to, like, I'll just sleep in another room. I'll sleep in another bedroom. I mean, which I don't think is great for relationships, but that's a different topic. So
Jackson and oh, this is a cool question. Jackson and Galveston, thank you so much for bringing this show. I thought I had only listened to it for 5 or 10 minutes, but I found myself so intrigued. I have to ask this question. Why do we sleep?
Yeah, that's a good question.
Is that a weird question?
No, I think it's a good question, but I mean, I think it's a requirement for life. That's why we sleep. I mean, every mammal that I know of has to sleep. So, in fact, they've done that experiment where they sleep deprive rats and they die after, I think 3 weeks of sleep deprivation or something, several weeks, but they eventually just die. So I tell my patients, we don't sleep because we want to, we sleep because we have to. I'm not really giving him the answer of why, but it's a lot of about stuff about nature. The why we don't know. We just know it is the way it is, right? I mean, like I said, it was only 1950, which isn't that long ago, that we didn't even know sleep had multiple stages. So we have a long way to go on the brain in general, right? I think our knowledge of the brain is pretty meager, considering the supposed science that we have, the tools, but how much do we really understand about the brain, other than we know speech is over here and vision's over there, and this is where your pituitary, we make hormones over here. But I mean, do we really understand, how we even, I mean, that's a big philosophical question. You can move that, like, thought and thoughts, and how do we think, and how do we have memories, and how does all our brain do all that stuff? It's pretty fascinating, because literally we're just a bunch of we're a chemical reaction. I was a chemist before I was a doctor, so at the very basics of who we are, we're electricity and chemical reactions, and that's pretty phenomenal in and of itself.
Dr. Ludwig, what does unhealthy sleep look like?
Unhealthy sleep? Well, that's
Is there a such thing?
a vague question. Unhealthy? Well, I think that maybe they mean unhealthy sleep schedule, or maybe they mean amount of time you need to sleep. I'm not sure what they're trying to say there, but I think when uh, each person needs a different amount of sleep, and that sleep needs to be quality sleep. That's the bottom line. So it's not always a quantity, it's the quality, and that's why sleep apnea gives you symptoms, is because it makes the quality. It's not the quantity. It makes the quality of the sleep that you're getting terrible. And the more events you have a night, the more terrible that quality is, the more poor quality you have. And so more of poor quality sleep does not make you feel better. So napping when you have untreated sleep apnea doesn't make you feel better because the sleep is broken. So most people I think most people would define good sleep as, they go to bed they fall asleep fairly quickly, 15, 20 minutes. And then they have a nice major sleep period. By major sleep period, I mean what it sounds like. The majority of the night they're asleep. And then they want to wake up to like an alarm clock. I mean, that would be probably most people's dream, is you close your eyes and then you open your eyes, it's the next day. I mean, I think that if you do that, you're like, wow, I had a great night's sleep. I think anyone would call that a great night's sleep. What you don't want is waking up to pee 3 or 4 times a night, and waking up for hours or half hours at night and staring at the wall or ceiling. I think those are, we call that insomnia. And undiagnosed sleep apnea will give you a lot of those. It gives you sleep maintenance insomnia. It makes your sleep feel like insomnia because it's always being interrupted. You'll pee several times a night. It's a very common symptom, especially for men, to wake up and pee 3 or 4 times a night, but they don't have a urination problem or a frequency problem during the day. And your quality's poor. So I think that's what defines quality sleep,
I just tuned in. I'm sorry if I missed this. What are the different ways you treat sleep apnea?
So the simpler question is the way I don't. The only way I don't treat sleep apnea is maxillomandibular advancement, or breaking the jawbone and the maxilla to move your face forward. That's what oral surgeons do. But I treat sleep apnea with a head and neck evaluation. I try to correct upper airway resistance, which means nasal congestion, sinus problems, tonsil problems, lingual tonsil problems, pharyngeal tonsil problems, epiglottic problems. Oral appliance therapy is a tool that we use. Air pressure certainly is a tool we use. Both nasal and some type of palate, tonsil, etc. surgery are tools we can use. Neurostimulation are tools. The problem isn't oftentimes the tools. The problem a lot of times is the willingness to have those tools be used. So, you may not want to do some of the tools that are available. You don't want to have a surgery, for example. You're afraid of surgery. You don't want to recover from it, or you don't like the fact that if we do surgery, there's no guarantee of the exact benefit you're going to get. There's a benefit. I can't put a number on the benefit before I do it, which I understand that, at least for throat surgery. That's what makes sleep so challenging, and that's why it's important that you do a lot of it, that you do a lot of training and a lot of experience, because it is a very challenging field. And the proof of the matter is that there are all the people who know they have it who don't treat it. That's the proof right there of how challenging sleep apnea is the fact that we know millions of people are walking around with untreated sleep apnea, and a lot of these patients have chosen to do nothing because they don't like the options they've been given. And they probably haven't been given all the options. Or realistically, they probably don't even know most of the options that exist. Would you say that's a fair statement?
Yeah. and I'm trying to get as many of these questions in as I can. We've only got about 3 minutes. What can be done to get insurance to cover my treatments?
Oh, that comes with going to a doctor who understands the requirements to get insurance to cover the treatments.
Oh,
So most insurance, well, it takes it takes a, this is a whole, I mean, that's a whole show, Steve. We should do a show on insurance. I mean, no, I'm being,
yeah, I think we talked about that because I got a lot of questions. People were like
you know,
upset. How
I
come
think the next
insurance?
show we just do an insurance show because
Yeah.
understanding healthcare, I mean, that's like a 4-year degree. Um, like insurance does cover sleep treatments. It covers appliance therapy. It covers air pressure therapy. It covers surgeries. It covers nasal surgeries, throat surgeries. It's most of these guidelines are published by Blue Cross, Aetna, United, Cigna. I mean, they're published. So it's just making sure that the right boxes are checked and you have somebody who knows how to present the information properly to the carrier. But the sleep apnea is a medical problem. No one disputes that. It's not a diagnosis that's in dispute. It's not a condition that's in dispute that needs treatment. So if you can't use air pressure, they will cover other things because they have to cover medically necessary treatments. And sleep apnea is it is a uncontested medical problem. It just is. It's a heart problem. It's a cardiovascular problem. It's a quality of life problem. So it is covered. To be black
Okay.
and white about it.
What? Um, when I had my sleep test, there was must have been like 15 or 20 wires hooked up to me. What is it like
It was
now?
more than that.
Is it the same way?
It was more than that, Steve. They probably had 20 wires just for your EEG. Yeah, like I was saying, it depends who does your test. There's
Mhm.
a ring out there. There's a watch out there that does it. I don't mean a watch like an Apple Watch. I mean there's a watch pat test. There's a then we use a kind of a 3 cent. We have like a 5 sensor test. It has a nasal cannula, oxygen sensor, chest belt, whatever. But all those home tests do. I mean, they're gonna find it if you have it for the most part, and they're all good screening tools.
We're running your phone number and your website on YouTube, but most of our people listen to it on iHeart and Spotify. Give everybody how they can reach your office.
Yeah, I think the most convenient way is it's really easy to remember. It's sugarlandent.com. So I'm in Sugarland and it's sugarlandent.com. So that's pretty straightforward. Of course, you can call us at 281-556-1102, but you can make an appointment or request an appointment online. And a lot of the treatments I talked about are all on my website. I think my website's pretty easy to navigate, straight to the point, very informative.
James will be back again with us next month. I bet you we'll be doing an insurance show.
Mm.
James, we can't thank. I'm so glad we have you, especially for someone who suffers through or used to suffer through sleep apnea. We'll see you again next month,
Yes, sir. Have a great day.
and I'll get that name over to you too.
Yeah, thank you. Bye-bye.
Thanks so much. That's Dr. James Ludwig. He is an amazing ENT doctor. He's with us every month. That's it for us today. We'll be back again with you next week with more Ask the Experts.
Thanks for tuning in today to the Ask the Expert show on W4CY Radio and Talk4 TV. Tune in next week and every week to hear more from our experts on personal injury, insurance, air condition repairs, estate planning, Medicare, and many other topics in the areas of legal, health, financial, and home improvement. See you next week.